our esteemed members of the Pharmaceutical Society of Kenya, members from the Kenya Pharmaceutical Association, and our senior respected members of PSK. Welcome to today's webinar. We'll begin at 7 or we begin at officially begin at 7:05 or closest to 200 we get. So just a quick question on that. Just probably on the chat box, keep us engaged on the chat box. When was the first time that you heard about family planning, and where did you hear about family planning? Just that's it. When was the first time that you heard about family planning, and where did you hear about it? Did you hear about a family planning services in a pharmacy? Probably class for the majority, and for the majority, probably on radio. Please put it on the chat box. Good evening, our esteemed members of the Pharmaceutical Society of Kenya. Good evening, all who are joining us from the Kenya Pharmaceutical Association. Good evening, our senior respected members of PSK. Welcome so very much to today's webinar. Today's webinar is on medical family planning, medical eligibility criteria. We're going to be taken through this wonderful training by none other than Dr. Anthony Yaile. He's a member of the Pharmaceutical Society of Kenya and also a member of the Toxicology Society of Kenya. Please, we begin when we get to either 200 or at 7:05. So in the meanwhile, on the chat box, kindly type in where you're joining us from and which was the first time that you heard about family planning. Which was the first time that you heard about family planning? I can see Dr. Ruben Coril says he's from Wakisingishu and heard about family planning first in high school biology class. Also, I can also see Dr. Nelisha Guaral is also joining us all today from Eldoret. When did you hear about the term family planning? Just type it on the chat box. Let's get to engage in today's webinar. And today's virtual CME is sponsored by none other than our great partners in Supply Health. Wonderful, Blinor Ahmed. You heard about it first in high school from Garissa County, Karibu Sana. Welcome so very much, Dr. Shital Shah. Dr. Jasprit from Mombasa. Dr. Christine Mutiso heard about FP back in high school, and she's joining us from Taita Taveta County. Wonderful. We are at 2:05, and it's exactly 7:04, so a minute probably to 7:05. Welcome so very much, members of the Pharmaceutical Society of Kenya. Welcome so very much, members of the Kenya Pharmaceutical Association. Welcome so very much, senior respected members of the Pharmaceutical Society of Kenya. Welcome to today's webinar on medical eligibility criteria. We're going to be taken through this meeting by none other than the chair, PSK South Rift Branch, Dr. Anthony Yaile, who is a consultant pharmacist and a lecturer of clinical pharmacology and toxicology, Department of Clinical Medicine, University of Kapianga. This meeting is in partnership with In Supply Health. For the webinars, we shall have the webinars CPD uploaded by Wednesday next week. Thank you very much for those who have contributed to a small chat. And I can see Dr. Caroline Wafula says that she heard about it first in high school. Dr. Naomi says she heard about family planning first in when she was dating. That is so wonderful, when she was dating. Welcome so very much. I'll take us through a few ground rules for us to be able to understand to be able to kickstart the meeting. So a few ground rules and announcements. Thank you so very much for participating in this session. Participants will remain muted in the entire course of the session. Please ask your questions via the Q&A tab at the bottom of your window. Questions shall be addressed by presenters on the Q&A tab. For PSK members, I have alerted you that for the CPD points by Wednesday, it shall be on the SPPP portal. This Tuesday's meeting is already on the portal. Last Tuesday's meeting is already on the portal. A point to note is that this session is being recorded and will be made available on PSK's YouTube page. So other than that, we go to today's agenda. Today's agenda is welcome and opening remarks from none other than PSK's side. I bring you greetings, and I bring you greetings from PSK, the President, Dr. Louis Mashogu, and also the CEO, the Secretary of the National Executive Committee, Dr. Lucas Nyabero. We're going now to go straight to the agenda of the day, where we're going to have Dr. Johnson Anyona beginning the day in our training for today. Dr. Johnson, are you with us?
Yes, Dr. Mbao.
Karibu sana daktari.
Thank you very much. Good evening, colleagues. It's a pleasure to join with you in this webinar series, and I'm excited about the session that we have today on medical eligibility criteria for family planning. My name is Johnson Anyona. I'm a supply chain advisor working for In Supply Health. I'm also a pharmacist and a member of PSK. In Supply Health is a health advisory firm that specializes on supply chain. And we are privileged to partner with PSK and KPA in one of the projects we are implementing called the Market Test. The Market Test project is focused on strengthening pharmacy provision of contraceptives in Kenya. And we are taking advantage of this webinar series to create demand and awareness about FP provision of in the pharmacy channel. So before I hand over to the speaker for today, as usual, I would like to start us off with a few survey questions. So Mbao, you will assist me here, posting the code and the link on the chat box. So please, whatever browser you have on your phone, on your laptop, however you are joining us with, go to www.menti.com, www.menti.com. Menti is MENTI.com. Once you are in, it will ask you for a code. You can put the code, which I am just typing right now. Few seconds. So the code is 7065973. 7065973. If you are facing any challenges, please let us know on the chat, and I'll be sharing my screen momentarily. I'll confirm that my screen is visible.
Well visible, Atari.
Thank you. So the first question is just to ask you for your agenda. Please specify your agenda before we get into the questions. We have 27 people so far in. I'll just pause for a few seconds to allow people to log in. Remember, we are doing this on Menti. The link is on the chat, www.menti.com. Menti is MENTI.com. And once you're in, it will ask you for a code, which we have shared on the chat as well. The code is 7065973. Seven zero six five 973. If you're just joining us, we are doing a survey on Menti, www.menti.com, MENTI.com, where you can repaste the link and the code. You will see it on your chat box, 7065973. Let's get more people on before we get to the questions. We have 60 people so far. We are at 75. We are doing this survey on menti.com, www.menti.com. The code is on the chat box. Please log in. Okay. I'll move us to the first question, but Mbawi, please keep on pasting on the chat for guys who are joining in. I can see we are at 300. Please, as many as possible, let's get into the Menti. Again, the link is on the chat box, menti.com, MENTI.com. And the code has been posted on the chat box, 706 5973. 706 5973. So I can see 58% are male so far, 41 are female. So we have majority of the participants being male. We're at 94. Let's get to 100. $98, two more, $99. There we are. So if we have 58% of the participants being male and 42% being female. All right, now let's get to the technical questions. So the following describes the purpose of medical eligibility criteria, except the following describes the purpose of medical eligibility criteria, except to base guidelines for family planning on the best available evidence, to determine the medical characteristics and conditions of a client, to address misconceptions about who can and cannot safely use contraception, to improve access and quality of care in family planning. So which one of the four is not the purpose, is not a purpose of the medical eligibility criteria? The following describes the purpose of medical eligibility criteria, except, is it to base guidelines for family planning on the best available evidence, to determine the medical characteristics and conditions of a client, to address misconceptions about who can and cannot safely use contraception, or to improve access and quality of care in family planning? So which one is not true? Which one is not the purpose of the MEC, medical eligibility criteria? Okay. Let's see what the correct answer is. So option B is the one that is not correct, to determine the medical characteristics and conditions of a client. And we will find out that that's not the only important thing. The important thing is to see which conditions are ideal for which method. So let's proceed to the next question. The next question is, category 1 in the medical eligibility criteria represents. What does category 1 in the medical eligibility criteria represent? Is it a condition that represents an unacceptable health risk? if the method is used? Is it a condition where the advantages of using the method outweighs the risks? Is it a condition for which there is no restriction for using the method? Category 1 in the MEC criteria represents what? Is it a condition that represents an unacceptable health risk if the method is used? Is it a condition where the advantages of using the method outweighs the risks? Or is it a condition for which there is no restriction for using the method? Lock your answer, lock your answer. No Googling, please. You're here to learn, so don't be afraid to choose the wrong answer. What does MEC category 1 represent? Okay, let's find out shortly. Is it a condition that unacceptable health risks, if used? Is it a condition where the advantages outweighs the risks, or a condition for which there is no restriction in using the method? So a majority are saying it's option 3, a condition for which there is no restriction for using the method. Let's see if that's correct. Yes, that is correct. Category 1 represents a condition for which there is no restriction for using the method. Thank you. Let's move on to the next question. So, what does category 4 in the MEC represent? What does category 4 in the MEC represent? Is it a condition which represents an unacceptable health risk if the method is used? Is it a condition where the advantages of using the method outweigh the risks? Or a condition for which there is no restriction for using the method? Please lock your answer, chap chap. Anyone just joining, please refer to the chat. We are doing this on Menti, menti.com, menti.com. Bao, please repost the link and the code there on the chat, and you'll be able to take part in this survey. Or pretest. So what does category 4 in the MEC criteria represent? I can see majority is saying that it's a condition that represents an unacceptable health risk if the method is used. Let's find out if that is true. Yes, that is correct. Category 4 represents conditions that an unacceptable health risk if they are used. Thank you. Let's go to the next question. Which of the following clients should not use injectable contraceptives? Which of the following clients should not use injectable contraceptives? Is it breastfeeding women who are 6 weeks and thereafter? Is it clients on antiretroviral drugs? Is it clients who have a current diagnosis of breast cancer? Or is it obese clients, that is BMI of 30 and above? Which of the following clients should not use injectable contraceptives? Breastfeeding women with 6 weeks and above, clients on antiretroviral drugs, clients with a current diagnosis of breast cancer, or clients with a BMI of 30 and above, that is obese clients. Lock your answer. If you're just joining, we are doing this survey on Menti. The link is on the chat and the code is also on the chat. Log in to respond to this question. The current question is on your screen, which is asking which of the following clients should not use injectable contraceptives. So injectable contraceptives are like DMPA IM, DMPA SC. Which one should you not use? Is it breastfeeding women who are 6 weeks and beyond? Is it clients on antiretroviral drugs? Is it clients with a current diagnosis of breast cancer, or clients who have a BMI of 30 and above? So I can see a majority are saying it's clients with a current diagnosis of breast cancer. Let's find out if that is true. Yes, that is the correct answer. So as we learn later on today, there are certain conditions that are contraindicated for certain methods, and for injectables, this is one of them. Let's go on to the next question. So select the conditions where all or any methods can be used. So this one, you select multiple. If you feel there are more than one, you are at liberty to select them. So choose the conditions where you are able to provide a client with any method that they want or they prefer. Is it post-abortion where there is no sepsis? Is it where the client is 6 months postpartum, that is after delivery? Is it adolescents? Is it clients with severe or advanced HIV? Lock your answer or answers. Remember, this one has multiple selection. So you can be able to select more than one option. So which of these conditions are you able to use any family planning method? Is it post-abortion where there is no sepsis? Is it clients who are 6 months and above postpartum? Is it adolescents? Or is it clients who have severe advanced HIV? Okay, let's see. 10 more seconds. Let's see what the answer is. So the first 3 are actually correct. You're able to provide any method to post-abortion where there is no sepsis, to clients who are 6 months postpartum, and to adolescents. They're able to use any family planning method. Okay, thank you very much for all those who've participated in the survey. We'll get a few minutes at the end to debrief again on these sessions. But for now, I'd like to hand it back to Dr. Mbau to invite the speaker for the day. Thank you.
Good evening. Thank you so much. Thank you so very much, Dr. Johnson, for taking us through that wonderful session. So welcome esteemed members of the Pharmaceutical Society of Kenya. Welcome so very much. We now go to the other part of our meeting today, and it's going to be by none other than Dr. Anthony Yaile, who is going to take us through a training on the medical eligibility criteria. So let me see, Dr. Yaile, are you with us?
Thank you very much, Mbao. Mbao, can you hear me? Confirm that you can hear me.
Yes, I can hear you loud and clear.
Okay, I want to thank you very much, my esteemed colleagues, ladies and gentlemen. I want to welcome you all to this session. Thank you for your sacrifice. Thank you for coming. And also I want to thank you, my association, PSK, for inviting me for this session. So I will be presenting on medical eligibility criteria. Oh, okay, sorry. So I'll be presenting on medical eligibility criteria, and I will look at the issues concerning medical eligibility criteria, or what we call the MEC. So the specific objectives for this evening will be majorly three. We'll try to look at the medical eligibility criteria and the rationale, the WHO. Then we'll describe the components of the MEC wheel and briefly demonstrate the skills in the use of the MEC wheel. Those are the main issues that we are going to discuss this evening. From our previous discussion, just a recap of our previous discussion on the topic. This is a continuation of counseling, and in counseling, there are tools or that we use or job aids that we use to ensure that we counsel our patient. And counseling is that interaction between one person to the other, so that you walk through particular issues, and that these particular issues, once you walk through a client, they are able to have an informed choice of the issues that they want. In that, when we look at now at contraceptive use, we are able to walk around and ensure that they pick the correct contraceptive method. Then, when we come now to the MEC wheel, the background of the MEC wheel is that, or the MEC, or the medical eligibility criteria, is a guideline that usually is given by WHO on the various issues or methods of use in the context of health issues and conditions. And this guideline was first published in 1996. You know that WHO usually works with experts, different experts from various countries, and they come up with various guidelines that we have. The current guideline, and they always review them. The guidelines are always reviewed, and the current that we have is 2015, and that is what we use, the medical eligibility criteria. And you can get this information from the WHO website. I think, Bao, you need to just post this website so that members can be able to just pick up the information. So what is the rationale? What is the safety criteria of the medical eligibility criteria? For each and every contraceptive method that we use, the criteria usually is whether the contraceptive method worsens the medical condition or creates an additional health risk to a client. So that even when you are counseling, you are trying to look at the conditions that this client has. Like, for example, from our pre-test, we looked at there are issues to do with breast cancer, severe HIV/AIDS, which we are not supposed to give a contraceptive because there could be other pre-existing condition, other drugs that the client is using that will interact with contraceptive. The other issue is whether the medical circumstances makes the contraceptive method less effective. And this we mean there could be some interaction of these drugs in terms of safety and efficacy. And therefore, the safety of the method should be weighed along with the benefits of the contraceptive method. Yeah, so that as a pharmacist working in the community pharmacy, you should weigh the options that you're going to use based on proper counseling. And I've insisted, counseling is very important, because from counseling, you go on with the client and you're able to pick out these issues. The other issues is about the different parts of the MEC, the WHO MEC, that is the medical eligibility criteria, in that it's divided. When you look at that guidelines, it's divided into two areas. Part one usually describes the recommendations, how these recommendations were developed. The experts sit down and they recommend various changes that were there. And then the part two, they contains the recommendation that describes how to use these methods. And for purposes of our discussion this evening, we are going to focus on part two. Yeah, we are going to focus more of part two. And these recommendations, as I said, they are contained within this document, and they are based on latest clinical epidemiological data. And that is why they are always reviewed from time to time. Yeah. And these safety criteria and guidelines, they are they make it very easy, so that they form what we call job aids, tools that are available, and they will help us as service providers to be able to actually counsel and ensure that we are able to effectively counsel and give this contraceptive method. And we have two, of course, we have other job aids that we are, for those of us who have already started practicing, we have other job aids, but majorly for MEC, the MEC wheel or medical eligibility criteria wheel usually is a document that has been published, research has been done, and it is an easier way of our reference material that you can always refer, and you are able to ensure that you categorically know which contraceptive method you are going to use based on the various conditions. Then these aids are also, the WHO has made a wheel. Of course, it is custom made to various countries. For Kenya, this is how it looks. It has colors of our country, and we have criteria. On the MEC wheel, we are going to discuss on how to use it. This is a job aid that each and every pharmacist who is giving a service, a contraceptive service, should always have it, because it's very important, especially when you are giving these medications. So category one, it is categorized into 4 areas. We have category 1, category 2, category 3, and category 4. And category 1 is usually, we can use the method. We can use the method in any circumstance. We are going to look at the details of this. And then category 2, you can generally use the method based on the reference. And then category 3 and 4, generally, you only use the method if the risk outweighs the benefits. And this risk could be cardiovascular events, cancers, advanced HIV/AIDS. You may be having other medications like anti-TB agents that are there. Next. So when we look at category 1, maybe we go into details now. Category 1 on the MEC wheel is that we use the method in any circumstance. Remember, the wheel is just an aid, a job aid that will assist you, a tool that will assist you in making a decision when you are in your consultation room. And we say, for those in community pharmacy, for you to offer this service, you need to have a private room. You cannot just offer this service on the counter. In that the condition in which there are no restriction on the use of the method. I think many of you answered this question correctly, in that all women can use maybe emergency contraceptive, that's just an example, safely and effectively, including women who cannot use ongoing hormonal contraceptive methods. And we've looked at an example, for example, patients who are breastfeeding, of course, this will depend on the type of contraceptives. Like breastfeeding women, usually we use POPs, yeah, post-ectopic pregnancy, rape cases, obesity, and of course, drugs. We also need to look at which drugs are these, yeah. However, category 1, you can use the method, yeah, and we have many other examples, like for example, adolescents, yeah, post-rape cases like EC contraceptives and many others. Next. Then we have category 2. Category 2, we always say that you can generally use the method. You can generally use the method, and in that the condition where the advantages of using the method outweighs the proven risk, what we call the theoretical risk, in that history taking, counseling is very important, so that you are able to pick up this condition. For example, you have a patient with cardiovascular events, yeah, cardiovascular diseases, and they have multiple risk factors, things like ischemic heart disease, they have DVTs, yeah, and they have history of maybe venous thromboembolism, you have history of stroke, history of ischemic heart condition, heart failure, severe migraine, yeah, you categorize migraine, especially with aura. These are generally the condition that you, as a pharmacist, you'll make a decision on whether to administer or give the service different types of contraceptive method. Next. Then we have category 3. Generally, category 3 and 4 in practice, those who have been practicing on family planning, category 3 and 4 are generally, we don't use the method. We always say, unless you are you have no otherwise, then you only use the method. You do not use the method unless there are no other option. Yeah, actually, we do not use the method because this theoretically there are no. I mean, there's a high risk. Yeah, there's high risk that outweighs the use of the method. Category 4, as I said, 3 and 4, they are similar. They are unacceptable with high risk if the contraceptive method is used, and we always say method not to be used. We do not use the method. And these conditions will include breast cancer, as some people have said, ischemic heart conditions, and all other conditions. Mbao, I don't know if I'm still clear. Am I still there? Please confirm. Can you still hear me?
Yes, with us.
Yes, Doc.
Yes. Okay. It's very important to know that I could be talking alone. So thank you. So those are the categories generally that we use. Probably for us to be able to understand, maybe you can move to the next slide before I show a demonstration. Wow. When we are demonstrating on the skills of make will, generally this is a practical session. However, I will try as much as possible to make you be able to see what we are saying, in that the will usually have condition, have 2 areas. it has the inner disc and the outer disc. Actually, it's a wheel, just a wheel that has been made, in that the inner disc usually has the contraceptive method, the different contraceptive method, whether it's combined oral contraceptive, progesterone only, injectable, implants, copper IUD, BTL, and all that. Then the outer ring or the outer rim usually is the medical condition or characteristics. For example, a medical condition could be a cardiovascular disease. Yeah, it's a condition. And hypertension, for example, diabetes, yeah, smoking, issues to do with headache. Which type of headache? Is it migraine and non-migrainous? Then medications is a condition, yeah? And the characteristic could be the different types of drugs. Antiretroviral therapy, you have patients with antiretroviral therapy, anticonvulsant agent. And then another condition could be HIV/AIDS as a condition, yeah? And in HIV/AIDS, we have the classification, the WHO class staging, yeah, especially severe stage 3 and 4. Then we have STIs and all that. So maybe before we go to summary, allow me just to present a WHO make wheel so that you can be able to appreciate what I'm saying. Really, these are practical, but just let me show you what I mean. Mbao, can you see, confirm you can see my presentation?
Yes, we can see it.
Okay. So this is a diagrammatic representation of a make wheel. Of course, each and every country has custom-made the make wheel depending on their needs. I'll maybe show ours for Kenya. Kenya, as I showed you, is a green. I'll maybe later on show you how it looks like. But this is how it is. It's a wheel, actually. Yeah, you can see it is rotating. Yeah, as I said, the wheel, this wheel has two areas. It has the outer ring, as you can see, and we have the inner ring, this ring here and the outer ring. So maybe let's start with the inner ring. The inner ring here shows the oral contraceptive method. We have progesterone only, we have DMPA, all these are different methods of contraception. Then we have the conditions, yeah, the various conditions and characteristics. Like, for example, as I said, one of the conditions could be age. Yeah, we have age, a menarche that is below 18 years and has not started menstruating. Then we have 40 years and above, older. Then we have parity. These are conditions, cancers, yeah, drug interaction. You can see these drug interactions here, liver diseases, yeah, diabetes. So these are wheel that you rotate, yeah. Cardiovascular diseases, as I was saying, you can see stroke, ischemic heart disease. So now, for example, you have a client who comes to your pharmacy, and from history, from what you found out is that they have some cardiovascular events. Okay, so what you do, you rotate this make wheel up to cardiovascular. Yeah, you can see cardiovascular disease, and then within this slit you can see probably he has a history of stroke. So if the patient has a streak of stroke, the contraceptive method that you're going to use, as we said, you start with one, which is Mbao. Can you see this? You know, it's also good to just know if my people are understanding. You know, as a lecturer, sometimes you need to involve your audience. So you have a patient or a client, not a patient, but a client who comes to your pharmacy, has history of stroke, and I need to give a contraceptive a method. Which one will I give from this wheel, Mbao?
Copper IUD, sir.
Yes, copper IUD. From our description, category 1, you can generally give it to all the patients with stroke. You cannot give COCs, you cannot give PU POPs, and you cannot give DMPA. So another example, for example, a client come, maybe let me give an example of
Doc,
HIV/AIDS. I think that is what we saw. Yes, am I?
there was a question on obesity. Maybe you can also use that with as an example on the chat.
Yes, obesity. Yes, you just turn this way. There. Once you see obesity, let me know. But,
just, I think I saw miscellaneous. Please go to miscellaneous.
Miscellaneous. Okay. Yes, miscellaneous is here. Obesity. Daktari Anyona, which contraceptive method will you give to a patient who is obese? Or not a patient, but a client who comes to your pharmacy and is obese?
You can give,
we are in a practical session, so I will want to interact with you and so that they see we are able to learn. Yes, you can give.
You can give copper, you can give implants, you can give DMPA, you can give POPs, you can largely give COCs since it's
Yes.
category 2. Yeah.
It's category 2, and we say we generally give if the others cannot be given. So generally we have an option here, and if you have a client who is obese, then you have different options. Copper IUD, if it's in your pharmacy, you'll cancel, and if they have agreed that they have to take copper IUD, then you refer accordingly. Implants, these are long methods, then these ones you can administer in your pharmacy. Dr. Mungoma, I've heard that you're around. Which other methods, maybe for based on understanding, which other condition?
Thank you, Daktari. I think you can just continue. I'm following.
Okay.
Yes, thank you.
Yeah, that's okay. So I hope this is very clear. I think there is one other question that was HIV/AIDS. I think that is what was asked. Is that true, Anyona, Dr. Anyona?
Yes.
Yes. HIV/AIDS. A client with HIV/AIDS. Mbao, which contraceptive methods will you give from our MakeWheel?
Daktari, Mwalim, you can give category, you can give combined pills and combined injectables, progesterone only pills, DMPA, and implants.
You notice
through the G.
Yes, that is very true. I was so you notice, even as you are giving this, there are some letters that are above here. So these letters have meanings. So here you click here and you find out what is the meaning of G. Yeah. So you can give if on ARV therapy, except if the patients have ritonavir or boosted, that is, except ritonavir boosted ARVs, then you go to category 3. So you are giving these drugs, but with caution. That means you need to find out, because you may get clients who are HIV/AIDS, but the combinations are different. So that's what it means, that you can give if on ARVs, then it's category 2, except ritonavir boosted ARVs, then you go to category 3. I hope that is clear. Maybe you'll ask questions later, but that is how generally we use the make wheel. As I said, is a tool, is an aid that we always use in our, we can always use in our. Probably let me show, I think you can see, this is what, how can this be seen? My wheel, this is the Kenyan wheel. It's similar to.
It is not that clear, Daktari, but it's being seen.
Okay. So this is what the Kenyan wheel is. This is how it is. You can see it also rotates. It has Kenyan, it is custom made to Kenya, similar to the one for a WHO, but this is how it looks like. Similar, you just move around, you just turn it around. It's a very easy tool to use for this. So maybe you can reshare again the slides, Mbao, before we have questions. Reshare my slides. Yeah, just go to slide 14. Is it back? Just go back, please, back. No, yeah, there. No. Category 4. Next. There. So what I was saying in summary, no. Behind, just go back. Bow, just go back. There. So this is what I was saying, that you've already seen that the inner disk is, it shows the method, and then the outer disk or the outer rim usually is the condition and characteristics. And condition is the medical condition mostly. And this medical condition, what are the characteristics? Like, for example, if you have sexually transmitted infection, which is a condition, what are these characteristics? Maybe you could be having gonorrhea, STIs, increased HIV/AIDS, and all that. Yeah, next. So in summary, what we are saying is that the take-home message is that your clinical judgment based on the proper history taking will show that you need always to use agents for category 1, and that the other 3 and 4, majorly you should not use them. You should not use those methods. You always need to refer accordingly. So that marks the end of my presentation. I return back to Mbao. Thank you very much. Next.
Wonderful. Thank you so very much, Dr. Yaile. Asante sana. So I'll request Dr. Nyona. Dr. Nyona, are you able to come back?
Yes, I'm here.
Okay, take it over, Daktari, so that we go now to the Q&A part.
Okay, you want which one do you want to go first? The Q&A or the debrief?
Do we go through the Menti? We'll go through the Menti, then the Q&A.
Okay. So that's fine. Let me share.
So I think on the Menti, you just need to go to the last 2 or 3 questions.
Exactly.
Just to.
You can see my screen?
Yes, we can see.
Yes. So this is one of them, Doc.
Yeah.
Which of the following clients should not use injectable contraceptives?
Yes, as we saw, cancer is a condition, and the various cancers that were there. Then if your client has breast cancer, cervical neoplasia, and all that, then we should not use inject. Actually, it's category 4. Breast cancer for the make wheel, you can only use copper IUD. Can I show maybe, I don't know, let me present, Anyona, for
Sure.
purposes of that question, allow me to present the make wheel so that we We
Yes.
are there.
Okay.
On cancer, where is the Mercury? Yeah. Bao, can you see the presentation?
Yes, Daktari.
Yes, you know, for us to be able to understand, so here is cancers. You can see cancers, breast cancer, all is category 4 apart from copper IUD. So that answers the question. For cervical cancer, you realize copper IUD is category 4, so you can use the POPs, yeah, for cervical cancer. But for breast cancer, which is common, a majority of COCs, POPs is category 4, so you can only use copper IUD. I think that's answer that question. Yeah, so you can see we can always use a make will to make a fast decision on the various contraceptive methods that we can use. Yes, next.
Thank you, Daktari. So yeah, so that was the correct answer. You shouldn't give injectables for breast cancer.
Yes.
Okay, next
And
question.
Next,
all right. Next question is, select the condition where you can give all or any methods. Select the condition where all methods can be used. Yes, Doc?
Yes, I think this was category 1, where you can use all the methods, and we say in whichever circumstances. So postpartum, 6 months postpartum, after you've given birth, you can give the method. Adolescence, post-abortion sepsis, you can always give the method. So these are category 1 conditions. And severe HIV, I did think we looked at this. Severe HIV/AIDS, depending on the category, you need to check, because if it's severe HIV/AIDS, it means that he has antiretroviral drugs, and they could interact with, especially the injectable and oral contraceptives. Next.
I think those are the two questions that had the practice.
Yes. So I think
Okay, Dr. Mbao, back to you for the Q&A.
Okay, thank you so very much. So the first question is from an anonymous attendee. Do these contraceptives contribute to yeast infections after administration? Dr. Mungoma, what is your take on that? Dr. Yaile, do these contraceptives contribute yeast infections after administration?
From our clinical guidelines, they do not contribute to yeast. That is candidal infections. These contraceptives do not contribute. And that's why history taking is important, so that if a client maybe is using some antibiotics, then you're able to pick it out. Otherwise, they do not contribute to yeast infections. Thank you.
Asante. The other question.
Yes, Mbao, sorry, I was muted.
Yes.
But yes, I support what Dr. Ilya said. But of course, there are those clients who might be susceptible. But as he has said very, very clearly, there is no direct connection between birth control pills and yeast infection. However, we all know that these pills have hormones, and that these hormones can control, disturb the body's natural hormonal balance, and that, of course, can can manifest in very many ways, including yeast infection. But clearly, what we are saying is that contraceptive pills do not have a direct effect on yeast infection. Thank you.
Asante. So a quick one also from Dr. Joseph Mureithi. How do we mitigate potential risks associated with the long-term use of some medications to control birth Is there a structure for this in case?
Well, I did not get the question clearly from my esteemed colleague, but I think what he's trying to say is that how do we control, maybe if you are to take POPs, for how long will you take the POP or whichever type of method that you've selected? This really will depend on the client, will depend on the preference of the client. In terms of spacing, you know, we are giving this to prevent, to control our family. And what we want to say is that this will depend on the counseling that you've given to client. What is the needs of the client? You know, your work as a counselor, as a service provider through counseling is to facilitate that process of ensuring that you get to know what your clients, you move with the client and get to know what they need. So to answer that question, this will depend on the preference, on the needs of the client. I don't know, Mike, what you have to say.
Yes, thank you, Dr. Aile. I think what we need to really emphasize on is counseling, as you've said, which is quite distinctive from advising. Because with counseling, you're engaging this client. With counseling, your make wheel becomes a very, very important tool in determining what is the best, and two, being able to empower this client to be able to report anything they feel may be associated with the contraceptive. And I'm very, very clear by saying that maybe, because if a client is going to be put on one long-term contraceptive, for example, an intrauterine device, and that the client maybe, or an implant, and they have it for 5 years, or they have it for even longer than 5 years, and there are other predisposing sort of factors or environmental conditions. It could be stress from work, it could be other lifestyle issues, whatever they eat, that could bring in other, other issues, other medical issues within the time when they're taking the contraceptive. That simply means that if that is the case, you need to follow up with this client just to see, is there an association between the contraceptive and anything else that is emerging, or these are the things that are emerging from this client associated with other things. So here, counseling as well as proper follow-up is so important. This, again, we're saying that if somebody is taking a long-term contraceptive and they develop a condition where they also have to take long-term medication, for example, painkillers, or they become hypertensive, or they realize that they actually had a genetic condition, then, all these things have to come into play, and maybe a review of that contraceptive that is being used at the time may have to take place. But that conversation through counseling has to be done to ensure that the patient is safe. Thanks.
Asante, Daktari. So probably to go through the chat box, and I requested us to put our questions on the Q&A. So one comment by Dr. Ermias Terefe. He has given 2 comments. Let me read them out. First, a long-term effect of contraceptives on fertility is controversial. The important point is clients are taking the same hormone in the body. Hence, fertility will be regained when the contraceptive is stopped. So what is your take on that, Dr. Yaile and Dr. Mungoma?
Thank you. Maybe let me start. This is a good comment from Dr. Ermias. And of course, as this is what I think my colleague MTM man, Mureithi, was saying, really, this will depend on the type of contraceptive method and counseling. Of course, different clients react differently to this contraceptive method. But of course, because they are hormonal, of course, fertility will not come immediately. Really, it's not even fertility, but issues of pregnancy, fertility. It will not come immediately, and this you pick it up. This is part of what you're supposed to inform your client, that if you're to use different methods, especially hormonal, injectable, you need to be aware that, of course, there are disadvantages, there are demerits. That does not mean fertility will not come. It will come. And these are things that you need to inform your client as you move on. However, I appreciate the interactions. I think this is a very good topic and interaction on the various methods. I don't know, Mungoma, what is your say?
Yes, Dr. Aile, you said it really well. I think this goes down again to counseling, and part of counseling is to openly discuss and inform clients about the possible side effects. Underline the possible, because this simply means that it doesn't apply to everyone. Some clients will not have any side effects. Some clients might experience side effects immediately. Some clients may experience side effects which may wear off, and they are able just to continue comfortably. So as regards fertility, when you're administering the injectable, the hormonal contraceptives, it is important to also inform the client that in certain circumstances, some clients may have a delay even up to 12 months or even 18 months before normal ovulation comes back, which may influence their ability to get children. So that when they say yes, they make an informed decision. But it is very, very clear from science that contraceptives do not permanently block fertility. They just delay this. They may delay this fertility when you stop using them.
Actually, someone has just rightfully said is that they are temporary infertility. Actually, is one of the side effects that you need to inform the client that, and that is one of the indication, because you are actually delaying temporarily fertility. So generally, counseling. I think that is the take-home message. Counseling with evidence. You as a pharmacist, you really need to have this knowledge and evidence. So thank you. Thank you, Mbao.
Asante. Asante sana. So let me see if there's any other question that is left for us. There's another from our esteemed senior, the Vice President Practice at PSK. From evidence point of view, majority of clients who use FP methods are not well educated in detail on merits and demerits of various family planning methods. How can a proper patient education be implemented at the community pharmacy level of practice to be sufficient enough? Could there be a possibility of an evaluation tool? Dr. Mungoma and Dr. Yaile, kindly comment on this. And probably also Dr. Anyona, you can chip in on this.
Maybe I can just go fast. I think this comment together with the question really is answered by our presence here. Part of this is a series of webinars and a series of trainings to empower pharmacists, whether they're community pharmacists or even clinical pharmacists, with knowledge and be able to competently engage clients as regards provision of quality family planning services. So part of this provision means then you are able to educate, you are able to provide correct information, you are able to demystify, and you're able to guide some of these clients to make informed or very good choices as regards family planning services. Part of this, provision, which has been mentioned in other webinars that we've had, is having a very clear referral system for those that require referring Remember, you cannot handle everything. You cannot handle all manners of cases, but you need to know where you can refer this client so that clients who come to your premise are able to leave satisfied or can actually come back if they are not able to get all the answers from you, but you refer them to a facility where they can get maybe whether it is testing, whether it is further screening, or very, very specific forms of contraceptives. Dr. Aile?
Thank you. Thank you. I cannot re-emphasize more. In fact, what we are actually doing is what is required. Last time we talked about counseling and the various methods of counseling, how to counsel our clients. But of most important is the information. You know, information is power. And in that case, for pharmacists actually working in Nairobi County, we'll want to give you more of this information. We've even called, I think Bao has made a call that we need to train you so that you have more information about this. So we'll be training you in the coming days. So ensure that you get into contact with Mbao so that you are trained well, because part of what we need is getting information, getting to know how these things work and applying the knowledge for the sake of our clients. Thank you.
So probably as we wind up, Dr. Anyono, come in with your parting shot and probably a comment towards that. And what are the efforts that we are making for that?
Yeah, so I think this is one of them. There are opportunities to upskill ourselves. I know the hands-on family planning training during our time, if I can say, was not provided. Even during the internship rotation, we never really rotated in the FP clinics. But I know things are shifting, and there are efforts to even include some of these practical skills in the internship rotation, in the pre-service curriculum, and even now in service, as has been mentioned, there are opportunities for capacity building. Various partners are offering these trainings, and even the webinars that we are having. So the opportunities are there. And for family planning, I think my take is really it boils down to the client and their client's rights, of which counseling, dignity, respect, privacy, confidentiality, those things, we really need to take care of them when we're offering our services to the client. So I'm seeing a point where even regulation will have to force us to be able to offer these high quality contraceptive services if we want to stock and sell contraceptive methods. So that's the general direction that I'm foreseeing our sector or our practice taking. Thank you.
Asante sana, Dr. Johnson. So probably, what is your closing and parting shot of this, Dr. Johnson? Then we go to Dr. Yaile. Ladies and gentlemen, we are not yet done. We are probably, we have 15 more minutes to go. And whatever that is left is the most important for us. So Dr. Anyona, you can go ahead on your parting shots.
Yeah, just to thank the speaker, my co-panelists, and all the participants. It's been a very insightful, hands-on topic. So much thanks to all those who are involved in this. Thank you.
Asante. Thank you very much, Dr. Johnson Anyona. Dr. Yaile, there's something I've posted on the chat box and you had commented about it. Give us your parting shot as you share with members what it entails.
Thank you. Thank you very much. Thank you very much. Thank you all the participants, my co-panelists, my senior Dr. Mungoma, our facilitator in supply. Thank you very much. At first, this topic was very tough for me because really during training is a hands-on practical, but I appreciate that we've used all the methodology to ensure that we comprehensively tackle the topic. And I think these are the areas, maybe Anyona and other partners, that we need to pick up and have a soft copy model of make will. This is just a challenge that we do not have a custom-made make will for our country. So these are the areas that maybe you can pick up. We know we are moving online, digital, and you can see the digital make will works very fast compared even to the physical one. So these are areas that maybe a take-home message. Number two is about training. PSK, in collaboration with partners, is inviting us, pharmacists working in community pharmacy. We are also focusing on interns. Interns also, we'll want them also to be trained between 9th to 13th and 16th to 20th. Please click on the registration button, on the chat button. I think Mbao will send this. We have a chance for you so that you gain this knowledge. This is your chance. This is what PSK wants for its members. And I'm sure this is what our Vice President, who is here, this is part of what he has been advocating. So on behalf maybe of PSK as one of the NGC member, with permission of our Vice President, I think this is a good opportunity for pharmacists. Intern pharmacists, we welcome you to just pick up the training, and those working in the community pharmacy. Otherwise, thank you very much. Thank you for the opportunity, and we are going to move on well. Thank you very much. Asante sana for listening to me.
Asante sana, Dr. Yaile. So just before we leave, ladies and gentlemen, we are going to be having our main conference. We have noted Kumu Junge, who says that please include metropolitan areas, not just Nairobi. For example, Ngong, Rungai, Kitengela, Thika, and Kikuyu. Kindly fill in the form. We're going to handle that as it arises. So, ladies and gentlemen, we are having our 42nd annual conference this year. It's going to be in the next 4 weeks, and it's going to be at Diani Reef Hotel. We listened to you and we said yes. We're going to move from the North Coast. We're going to Diani. But just as we go about that, we are going not there to just have fun, network, and also make new friends. We're also going there mainly for specific scientific purpose. Those in the hospital, you have been doing work all year long. You've been doing researches. For those who are doing their master's levels, you've been doing all these researches. Where do you present? So without further much ado, ladies and gentlemen, allow me to welcome the lead with abstracts at in the symposium committee, and also a national executive committee member. That is none other than Dr. Mungoma. Just give us a brief on abstract, on the abstract submission for the conference. Karibu sana, Dr. Mungoma.
Thank you very much, Mbao. And again, good evening, everyone who has come to this webinar this evening. I think I just want to take some few minutes to talk about abstracts as regards the upcoming conference that we're going to have between the 1st and the 5th of June. We are well aware that it is important for us to engage in scientific research, which not only enhances our skills, but also improves our knowledge and allows knowledge sharing. So the upcoming conference is a scientific conference, and we are expected to present, share, or listen to work that has been done by our colleagues. And I thought it was important also just to share a guide or a brief on this abstract submission, because I've also had inquiries from people as to how they need to submit this. For those that are joining this webinar for the first time and probably have done some research work, this is a very useful and a very good platform for you to come and present your work. Remember, as compared to some other international conferences, we want you to come and present, and we do not charge for presentation. Let me be clear, we have our charges for participation in the conference, but we don't charge for presentation or being a presenter. So just a brief again, abstracts need to include sufficient information about the nature and significance of the topic or the area of the study. And it basically summarizes the results of the work that has been done. So this is a brief outline, a summary of the whole project. It needs to have an introduction, body, and a conclusion, ideally. And it must be understandable to a wide audience. Remember, sometimes people do write-ups and it's only the writer who understands what they wrote. So it's important that whatever you write is understandable by the audience, and the people that come to the conference would be a wide array, including people who have just qualified recently, or people who are interns, to as far as professors. So it needs to be well understood. When you're submitting your abstracts, do not include charts or tables or figures. It needs to be very, very short. And the general layout of the heading, title of the paper, then first name, middle initial, and last name of the author. And then do not forget to include the name of the faculty mentors where applicable. So for us, what we are looking, what we're expecting is that your abstracts need to follow these guidelines, submit in Microsoft Word format, and in Times New Roman font, size 12, and it should not be more than 300 words in length. So meaning you need to really try and distill the most important information so that everything is squeezed within the 300 words. And while you're submitting, make it single-spaced and single paragraph. We're trying to make the booklet for the conference to be uniform and allow easy reading. So while you're writing, good writing style involves writing concisely in normal rather than abbreviated English. We sometimes use a lot of abbreviations, and like I said earlier, it might just be you who understands what you have written there. Avoid unnecessary contractions, making specific rather than general statements, because it should represent what you have done, so that you're not just providing general statements and saying, like, for example, generally that COVID seems to affect people who wear their masks wrongly. That is a general statement. Make it specific. So some of the basic components that we expect you to have in your abstracts is your problem statement or motivation. Why do we care about this problem? What practical, scientific, theoretical, or artistic gap in your research finding? And then the methods and procedures or approach. What did you actually do to get your results? Did you interview patients? Did you analyze samples? Did you analyze records? What exactly did you do? And then the results and findings. As a result of completing the above procedure, what did you learn, invent, create? What did you find? And then the conclusion and implications. What are the large implications of your finding, especially for the problem gap identified in step 1? So ideally, we want people to be able to present abstracts and make presentations that provide solutions or can give insights towards sorting out or solving problems that we have. And remember, we have quite a lot of problems in the health sector, not only just in the pharmaceutical sector. So I just put a sample here as a format of how you are meant to submit this. Have your title, and then have your first author, second author, third author, and then the correspondences for the authors, the department, institute, country, it could be the university, it could be a company, and so on, and the email addresses. And have your keywords, so up to 6 words that are arranged in alphabetical order. And then now the body of your abstract, as I have just described above. These abstracts are to be sent to the address that I've just shown there on the screen. That is symposium@psk.or.ke. This guide is going to be made available through social media or our other channels for anyone who wishes to submit their abstract for the upcoming conference. So that is all from me today, and we hope that maybe this provides a little bit of clarity or provides a little bit of stimulation for those who are hesitating or thinking of submitting their abstracts. Back to you, Mbao.
Asante sana Daktari Michael Mungoma ambaye ni mwenyekiti wa dhania katika kongamano letu la 42 mwaka huu. Nataka kabla tufunge, kabla tufike tamati kabisa, mtaniruhusu nimkaribishe Daktari Joseph Kathare ambaye ni makamu wa rais wa vitendo vya kitaalam, that is the Vice President Professional Practice, aweze kutupa kura zake za shukrani. Dr. Kathare.
Thank you, Dr. Bao. I don't know whether I'm able to speak Swahili like you, but I want to appreciate God for giving us this opportunity. And more so on behalf of PSK President, I want to thank Dr. Mugoma, our presenter, Dr. Yaile, and I think it's important for us to remember where pharmacy has been. And it is at this time that you should actually appreciate our sponsors for the event that is tackling family planning training. All of us, we can remember pharmacy practitioners, they are not allowed to talk about family planning for many years, including other healthcare workers. And today we have an opportunity through the supply and through our partners to position pharmacists to a level that after these trainings, we will champion for pharmacists to administer family planning methods in all public hospitals. So I urge my colleagues and all participants that let's take this training serious. Let's actually thank God for bringing along this kind of breakthrough to pharmacy practitioners. It has not been easy since the beginning of the curriculum, all the programs that we have to embrace pharmacy professionals to actually not even to administer, but to be trained on family planning from the Ministry of Health. So we need to recognize this kind of effort as has been put for many years. And here we are now to get the knowledge. And after knowledge, now we move to implementation phase. So I want to appreciate this effort and our colleagues and our partners. And I believe by the grace of God, I will see pharmacy professionals across the country being able to administer family planning treatment all over. And I know we'll be there. And from there now we'll be able to champion for reimbursement by the NHIF and other insurance companies for the service we'll be providing. So thank you so much, and God bless us as you continue supporting PSK. Thank you, Dr. Bao.
Asante sana makamu wa rais. Nami sina budi ila kuwashukuru sana kwa kujiunga na somo letu la leo, kwa kuweza kushikilia hadi tamati wa somo letu la leo. Somo hili letu tutaweza kulipata katika tovuti yetu ya YouTube. Tutaweza kuiweka pale Jumanne ijayo, itakuwepo pale. Sina budi ila kuaga ama kwamba tumefika tamati wa somo letu la leo. Alamsiki.
Thanks, everyone.
Good night, everyone.
Lovely evening. Bye.
Good night. Thank you.